Hi there, my name is Abbie Inman and I am a UNCG nursing student in my senior 440 rotation. As a part of this rotation, I have been shadowing and interning at Wesley Lawn Community Hospital in the emergency department. This is my recount of a gentleman that came in, and for all extensive purposes we will call him Mr. Roberts as his alias to protect his identity, but this is his story. Mr. Roberts was a 48-year-old male, and he presented to the ED via ambulance at 03:30 with an acuity classified as emergent due to a fall, which left him in a lot of pain with his knee and his hip on the left side. He arrived via stretcher and was classified as a musculoskeletal non-trauma. Upon arrival, his vital signs were temperature 98 degrees Fahrenheit, pulse 106, respirations 22, blood pressure 127/87. His O2 sats were around 97%, and his pain was a 12 out of 10, so he was obviously in a lot of pain. His initial assessment was unremarkable. His airway was intact, his behavior was relatively cooperative. He was in no respiratory distress. He denied any loss of consciousness due to his fall, although he did say that he got dizzy. He was alert and oriented ×3, and his skin was warm, dry, and intact. His past medical history included type 2 diabetes, hypertension, GERD, a history of an MI, just in recent months, that was only 2 to 3 months before, and he also had neuropathy. His current medications that he was taking at home were glipizide, metformin, regular insulin, all for the diabetes, metoprolol for hypertension, Nexium for GERD, and Lyrica for neuropathy. He reported no known drug allergies or food allergies. He was immediately put on bed rest due to his injury. He was obviously a fall risk, and as is customary for anyone in the emergency department or anyone that may be waiting on surgery, he was NPO, a nothing by mouth diet. He was given a 20 gauge IV to his right hand, and was also given a 500 milliliter bolus of normal saline. His basic metabolic panel showed that his glucose was 219, which is high, but not remarkable considering that he was a type 2 diabetic. His BUN was slightly elevated at a level of 24, right over the 23 marker there, but his creatinine was not high, so his kidneys were probably functioning just fine. His calcium was 8, which is a little bit low, and his CBC with differential showed that he had white blood cells that were elevated at a level of 14.6. He was well over that 10.5 level. His neutrophils were 79%. His absolute monocytes were 1.2. And any of these elevated blood cells, white blood cells, could be due to infection, stress, anemia. In the worst case scenario, it could be cancer, but I do not feel that that was the case with this gentleman. At this point in his stay with us in the emergency department, he was simply waiting for a room upstairs and waiting for surgery. So meanwhile, we took his CBG at 0500, which was 296, so he was given 4 units of Novolog. He was also given 4 milligrams of morphine at 0614 for musculoskeletal shooting pain, which was a 10 out of 10. And with this medication, his pain was reportedly reduced to a 5 out of 10, and the patient was able to sleep. At 0650, the patient was taken to X-ray for an X-ray of his complete left hip, and the results showed that he had a predominantly subcapital fracture of the left femoral neck with a superior displacement of the distal femur, which basically means that he obviously did have a broken hip, which created a lot of pain for him. It was quite a severe fall, apparently. He also had a CT scan of his lungs, which showed left basilar opacity that could have reflected atelectasis or pulmonary parenchymal contusion. He also had vascular congestion noted with minimal edema. and they reported that he had no pneumothorax. After this, after his CT scan, he was moved to TCU, where he was waiting on a room. That is our transitional care unit, where they either wait for a room or wait to be moved out of the hospital. And this was the time when it got pretty interesting for Mr. Roberts. He was transferred to a TCU bed from our stretcher, off of the stretcher from the ED, and he was obviously in a lot of pain when we did this. It's very risky to move people like this for risk of furthering their injury. But he was developmentally sound, but he was very agitated at this time. He was very verbal in what he wanted and how he felt about the whole process. So he just had not a great outlook in his mind. His vital signs at this time: his temperature was 97.5, his pulse was 109, his respirations were 16, his blood pressure was 113/75, and his O2 sats were around 98%. His pain was 10 out of 10 at this time, and after we had him moved in and settled, he said he felt scrunched, in his words. So we went back in and moved him up in the bed, and he was so verbal and increasingly agitated at this time, we did have to call Greensboro Police Department to come in and sit with him and stay at his bedside. He complained of being very thirsty, and we repeatedly explained to him that he was NPO for surgery, but he did not accept that and was still very agitated about it. I'm sure that was frustrating for him, but he did not accept his NPO status. He was given 2 milligrams of Dilaudid IV push for pain, and about an hour after that we realized that from the nurse's station we could hear a strange noise, and we thought it was the television for a second, but then we went in and checked on him, and he seemed to almost be having a sleep apnea episode, because he was snoring very loudly with almost a barking noise added in there. And so we put the pulse ox on him before we woke him up, and the one that was at the bedside we felt was not even accurate because of how low it was. So we got a handheld pulse ox monitor, and it was the same, and it was monitoring, it was reading 57%. So we quickly woke up the patient. He was arousable, but with a lot of stimulation. We had to do a sternal rub on him, and he finally came to, but it took a lot to get him up. We placed him immediately on a non-rebreather mask and called the physician, who then ordered Narcan to reverse the effects of the Dilaudid, because he felt that maybe he was experiencing respiratory depression because of this medication. We gave him the Narcan and expected for him to jump up and come right out of it, but he did not. He was still very almost stuporous and just very sleepy and just wanted to go back to sleep. So we figured that maybe it was not the Dilaudid that was causing him to act this way. So the doctor ordered a stat ABG, which was done, and a stat chest x-ray to rule out a PE, but nothing was found to that effect. So at that time, we monitored him, and he was slated to be moved to 2 West, which is a normal med-surg floor, but we had him moved to the step-down ICU unit to make sure that he did not further deteriorate before he had to go to surgery. He was moved to surgery later that afternoon, and his hip was fixed, but this was a good learning experience for me, just to know that patients, even though they look stable, we have to be very careful with them, especially when we're moving them from bed to bed, which may have been where his problem started. But I was really impressed by all of the nurses that came together and helped out with this patient, and for his good, we jumped in there and took control when there was a crisis situation, and I was just very proud of that.